This is a very important program from Kerala which they have initiated, and the intention to bring innovation in cardiac sciences and other specialities is, I think, quite commendable, and I must thank Kerala for doing this particular thing, which is in the field of research and development from an Indian company, which is very good. So we have been talking about cardiac treatments, cardiac investigations and everything, and we still are not able to reach that point where we will say that it is a treatable, it's a very easily treatable condition. Why? Let us look at this. That despite all that, the mortality with cardiovascular disease is still very high. And in India also, it is about 28% mortality because of cardiovascular diseases. And this data has been collected from the recent publications. And out of these patients, a sizable number of patients are young patients. Almost every week we see, in our hospital at least, we see patients coming in and not surviving also many times, who are below the age of 50 years. And that is a prime age for anybody in the society. So we have various risk factors which have been identified, which we know, and we have been working on them, controlling diabetes, hypertension, etc., and also looking at various other factors, genetic factors. But the problem is, despite that, we keep telling our patients, control your diabetes, control your blood pressure, do a regular checkup. Still, a large number of patients come back to us with acute MI. Why that happens? Nobody knows. So many times patients ask me, what is the cause of heart attack? I tell them that we don't know. Because that is the truth. We still do not know why cardiovascular events happen. We are just, trying to make something up, make some conclusions. Just risk factors are available. We do not have any cause and effect relationship. We do not even know what actually triggers these phenomena. And many times we see, 1 week back a treadmill test was done which was absolutely normal, and 1 week later the patient comes to the hospital and he dies. And of all physicians who are sitting here, experienced people, everybody knows these stories. So then they ask me, what is the use of doing these investigations? I tell them, really, I think the time has come and we have to say there is no need to do these investigations. And that is why in the lipid guidelines, we have started saying these things. That probably we are not on the right track. So look at this data. It shows that 43% of the patients who come with cardiovascular disorders have only one risk factor, and about 20% have no risk factor. They have been living a normal life, absolutely disciplined, walking 5 miles every day for the last 20 years, and they still have a cardiovascular event like stroke or a acute MI or acute coronary syndrome. So what is the reason? So we are in search of that reason, and let me tell you, these are patients who have not even high lipid levels. They are almost normal people from the society, and they have acute MI or acute coronary syndrome, and many such patients will actually succumb to this problem. So the next target, as is being discussed for some time now, is inflammation. Some inflammation is triggered by something. That also we don't know. But there are some theories which have been brought forward. So in view of that, because this is an innovation session, we are bringing forward to you this concept of inflammation, and let's see what we make out of this whole story. So look at this. The hsCRP, which is a marker of inflammation, as the CRP level grows across the levels of LDL or across the levels of risk factors, whenever the CRP is high, in all subgroups, the event rate goes up. So which means hsCRP, or marker of inflammation, is a common factor which is happening in many such individuals. So in 2003, we started with measurement of hsCRP, which said that the guidelines said that probably it will help. Then in 2010, we started, the ACCHA guidelines started saying that measure CRP in apparently healthy individuals, elderly people, to identify cardiovascular risk. And now, in 2013, we are saying that use of hsCRP for stratifying the risk for high-risk patients for atherosclerotic cardiovascular disease is reasonable, although it is still not as a guideline that you start doing HSCRP for everybody, but this is a very strong indication which is coming up, and so we start then thinking. So to establish that, we started looking at what causes atherosclerosis. That again, the answer is we don't know. And that is why the whole problem is we are not able to solve this serious problem of atherosclerosis, which leads to stroke, peripheral vascular disease, coronary artery disease. So look at this, why it happens. Basically, the triggering process is the oxidized LDL, which works as a trigger for inflammation. Why it enters into this, that also we do not know very clearly. Probably some inflammatory process actually makes these walls permeable, the endothelium, and that is how these molecules enter inside. They activate the monocytes which stick to the wall of endothelium. They get activated through the transgression process through the endothelium, and then the whole chain of events start. Because an abnormal molecule or abnormal person has invaded the endothelial wall, and then the whole reaction starts churning in, which leads to a lot of reactions leading to formation of dendritic cells, macrophages, and the various pathways are activated. The kynurenine pathway is one, NFKB pathway is another one, and all this leads to formation of more inflammatory mediators. A lot of inflammatory hormones are secreted, and that is the vicious cycle of inflammation which starts inside the endothelium. So some part of it is we are knowing, but we still do not know how exactly it starts. But then we have to start looking at this, how to control this, even if it has started. So we have to attack on these pathways which start triggering inside as soon as these LDL actually enter inside the vascular endothelium and inside the vessel wall. And then of course, as you can look at this, lot of activation, the foam cell formation, the platelet aggregation, and all those things start happening. And we have now identified many such metabolites, the NFKB inhibitors, and here you see that one of the important sites which we have identified is NFKB inhibitor site, which is actually a very, very simple, now I won't say drug, it is actually a spice which we use, which India has been using for the last so many years, and that is known as curcumin. Curcumin, as everybody knows here, is haldi extract, and we all know that traditionally it has been a healing agent in the most traditional ways whenever there is some injury or inflammation inside the body. So basically, the inflammatory stimuli, they start initiating all this process, they activate the IKKB, activation of NFKB pathways, and then all these reactions lead to these translocation into nucleus, release of inflammatory mediators, and then these cytokines, pro-inflammatory cytokines, addition molecules, all these processes start off in a very, very rapid way. And basically the rapidity with which they do, it leads to the different types of acute coronary syndromes or stable angina. So to prevent that, this drug, which is curcumin, actually acts at this site, which is activation of NFKB pathway, stops that, and then prevents translocation of this into the nucleus, prevents release of inflammatory mediators, and that is how this cycle is stopped or prevented. So it has multiple sites of action, and that is why it is much more effective, because if there is a single site of action, sometimes the other cytokines can activate the other pathways. So it has an anti-inflammatory role which has been identified, which decreases C-reactive proteins, decreases MI associated with CABG, significantly reduces serum cholesterol, prevents progression of diabetic nephropathy, and decreasing fasting blood glucose, HbA1c, and insulin resistance index. So various pathways and sites have been identified. Then the other pathway is the kynurenine pathway, which has a very important intermediary, which is 3-HAA, which has anti-atherosclerotic effect and reduction in LDL, which is led by this intermediary. And this metabolite is basically again a very important target which can be used for control of lipid metabolism, control of occurrence of acute coronary syndrome or cardiovascular events in patients who have initiated this activity. So this is the 3-HHA effect on plasma lipids. As you can see, reduction in plasma cholesterol and triglycerides have been seen by the use of 3-HAA, and also significantly reduces infiltration of T cells in atherosclerotic lesions. So at various levels it has been identified that this target or this mechanism is also something which can be clinically pursued. So basically it is an intermediate metabolite of kynurenine pathway which happens inside the vessel wall, and it has the following significant benefits: improves lipid profile, significant reduction in inflammation, and so on and so forth. But beyond these two, there are so many targets which have been identified to reduce inflammation. And let me tell you, this is one LPPLA2 inhibitor. I don't know how many of you attended that, some of the programs initially. In 2010, we were actually working on this, and many of my patients have actually received this drug, the anti-LPPLA2 inhibitor. And this drug was being studied in the solid TIMI52 trial, which we were part of that trial. This was a phase 3 trial. But unfortunately, many such drugs in this category actually did not lead to clinical benefits. And that is why this was a multi-million-dollar studies which were being done. I don't remember which company was doing it. I think GSK was doing it at that time. And then it was stopped in between because the benefits were not there, and it was taking a lot of money from that company to do this trial. So at this time, many such targets have been identified. They are being in various phases of studies. As you can see here, the pathways are all generally related to the inflammation. So basically, inflammation is something which has been identified now, and probably one of the pathways of aspirin's effect on reduction of events could also be anti-inflammatory effect. Statins effect could also be anti-inflammatory effect. So despite optimum therapy with current drugs, still 1/3 of low risk individuals with 0 or 1 risk factor have been known or seen to develop a atherosclerotic cardiovascular disease. So that is the starting point. Why these people who are taking all the care, all the treatments, still they are developing these events. So probably we have still not reached that point, and inflammatory pathways which are being pursued right now with the new ingenious drugs could also be a very, very important ways of controlling this problem. And controlling inflammation will help improve cardiovascular outcomes probably, and may also then subsequently reduce morbidity and mortality in patients with cardiovascular diseases. So basically this new pathway, this innovation is a very important thing, and I am sure soon we will have studies where we will do some trials using this molecule, which is curcumin and 3-HAA, in patients who are already being treated, or even in individuals who are at high risk for developing cardiovascular diseases. So this is all I wanted to share with you, that we are on a different pathway again at this time. And let me tell you, when LPPLA2 inhibitor we were investigating, the promise was that if LPPLA2 inhibitor was effective, there would be no occurrence of ACS or AMI. Because if inflammation is controlled, there will be no heart attack, there will be no stroke. There will only be stable plaques, no more than that. And any such drug which will become effective, it will just finish all ICU admissions, all acute MI admissions, all thrombolytic agents, no acute coronary angioplasty will be performed. So that is the dream. So with this, I will stop here, and thank you very much for your attention.